I'm going to speak on a stroke physician's perspective. Is it working? Yeah. I'm going to speak on a stroke physician's perspective of atrial fibrillation. For a cardiologist's perspective, we have Dr. Shom Kumar somewhere sitting here. So I'll give you a very sort of hands-on overview of how a stroke physician might feel dealing with atrial fibrillation and stroke. So those are my disclosures. I'm also going to speak about hospitals being a magnet for atrial fibrillation. So I think I've always said that hospitals probably need to do more to detect and anticoagulate patients with atrial fibrillation. We'll talk a little bit about anticoagulation strategies and some case studies. I've got 40 slides, but I've only got 15 minutes, so I'll try to give 20 seconds per slide. I've got plenty of people's photographs. Apparently, we're allowed to use photographs, but not names. So this gentleman, only 63, came to a hospital clinic, was found to be in atrial fibrillation, but he's only 63. This was the time when this is 2012, yeah, when we had not yet started using the CHADS-FASC. It was available. So on the CHADS-2 score, he was scoring maybe 1, maybe 2, so he wasn't anticoagulated. The poor man ended up with a large infarct and is now permanently disabled. Just in general, I think there is plenty of data available out there. 5% for over 65s, 10% for over 75s, and 20% for over 85s. That's how I remember the prevalence of atrial fibrillation. I'm not sure if this is intermittent. Should I just talk without? Yeah. I'll just talk without, actually. So as we get older, it's very, very prevalent, atrial fibrillation, so seriously important condition. I've done a series of audits in Preston to look into atrial fibrillation and stroke. And this is something we did about 5 years ago, actually, and my student got a national award for that. We looked at 500 consecutive acute medical admissions over the age of 50 and found that 20% of them have atrial fibrillation. It just shows that atrial fibrillation is there, and especially in your acute admissions. Atrial fibrillation increases the chances of admission, increases the chances of mortality as well, as you know, it doubles mortality. Okay, so I wanted to look at the stroke unit as well and see what proportion of patients who come to the stroke unit have atrial fibrillation. If you look at the published literature, about 15, 20, or 25% of patients with acute ischemic stroke have cardioembolism or cardiac source of emboli causing their stroke. So we found a very similar sort of level. So 22% of the acute ischemic stroke admitted to Preston were having atrial fibrillation, but the sad thing was only 12% were anticoagulated before they were admitted. So nearly 90% of these patients could have been anticoagulated. That is both a bad news and a good news. The good news bit of that, if you just try and think about it, is the patients who are actually anticoagulated are not coming in with acute ischemic stroke, which means anticoagulation is probably working to keep them away from the stroke unit. And this is my experience as well. Anticoagulated patients don't tend to have acute ischemic stroke. We also looked at care homes and found 20%, nearly 20% had AF. Just a quick recap. There are 9 points for the CHADS-VASC score. There's also 9 points for the Hasbled score. you see at least 3 points are common between the two. So as one goes high, the other also goes high. So the Chad's-Vasc score, 2 or more is important. For the Hasbled score, 3 or more means higher bleeding risk. But I've spoken to other physicians, and I think there is a general consensus that even if you reach 3 on the Hasbled score or 4, we're not actually going to stop anticoagulating our patients. We're just going to be more aware, more cautious, inform the patients of their risk. NICE guidelines have made it absolutely essential that we use the Chad's-Vasc as well as the Hasbled score. And hence, for medical legal purposes, I think we need a documentation in the patient's notes that these discussions have taken place. In Warrington, they do a good job actually. The pharmacy get involved with this, and they have printed documentation, printed patient information on the Chad's-Vasc and the Hasbled score, so which they give to the patient and then document that in the notes. So we know warfarin is a beautiful drug, but there is a very narrow therapeutic window. If you go higher, you've got a bleeding risk. If you go lower, you've got a thromboembolic risk. This is something very important and close to my heart, and this is just one example of many patients I see with this problem. This applies to both primary care and secondary care. So this single slide tells a big story. This is only a 63-year-old man, a father of 3 or 4 young adults, came in with a small hemorrhage in the left putamen, had a bit of expressive dysphagia, a tiny bit of weakness of the right hand. In the A&E department, in any hospital, we've always got a rush to move people on. Before we complete emergency treatments, people are rushed onto the wards. So before the patient was given coagulation reversal, they were moved onto the ward, and look what happened to them. And the patient died 4 or 5 hours later. The treatment was recognized, vitamin K was given, but the right treatment for warfarin-induced anticoagulation-related hemorrhage is PCC, which is prothrombin complex concentrate. There was also an error before that happened. The patient was given clarithromycin while they were on warfarin, so their INR jumped up, and that was the reason why they ended up with the first hemorrhage. And then PCC was not given in A&E, even though it was documented, because the patient had a 4-hour target to achieve. They got to be kicked out of A&E in 4 hours. So this slide shows that vitamin K is still important and must be given in A&E department, but can take up to 24 hours to work. What actually works within 15 minutes is something called PCC, prothrombin complex concentrate, available as Octaplex or Beriplex. I've got some good news. The NOACs have been notorious for not having a reversal agent, but this week we've got this earth-shattering publication from the New England Journal of Medicine. There is a molecule, a monoclonal antibody called idarucizumab. This is an interim sort of report that has been published for 90 patients. And this monoclonal antibody completely reversed the anticoagulant effect of dabigatran within minutes. I think this is going to become commercially available very soon. Boehringer manufacture that. Okay. Warfarin-related intracerebral hemorrhages are double as likely to die as patients who have non-warfarin-related intracerebral hemorrhages. We also did an audit in Preston to look at that, and we actually found 1/3 of our patients with hemorrhages died. Whether they were on warfarin or not, 1/3 of our patients with hemorrhages died. And even then, we don't take intracerebral hemorrhages that seriously. When somebody gets a cancer, we're all very worried. But when somebody has a small bleed, we're not. But 1/3 of them die in a month. We all know achieving therapeutic range for warfarin is exceedingly difficult. These are some of the major trials in anticoagulation, and they only achieved 2/3 of the time that their patients were in therapeutic range. I think this is one of the challenges with warfarin. So we looked at what might be the situation in a hospital. What we looked here was trials, but so we looked at our hospital just exactly a year ago now in Preston. And this is the bar we need to look at, 60.6%. So we found that about 60% of elderly people were in range for 65% or more. That is good. I thought it was going to be 50%, but it's 60%, so which is good. So, but that means about 40% of people are not in range for 65% of the time. Okay, so numbers needed to treat is only 12 for secondary prevention if you use warfarin, and numbers needed to treat for primary prevention, so for people who have not had any cardioembolism at all, is 37. I will just look at some anticoagulation strategies and leave you to decide what we should be doing. If a patient comes in with a TIA and has atrial fibrillation, we must give the patient anticoagulation on the same day. So the Royal College say in 2012 that should be anticoagulated with an agent that has rapid onset in the TIA clinic once intracranial hemorrhage has been excluded and if there are no other contraindications. In the past, we didn't do brain scans for TIAs, but now we do brain scans for all TIAs. So we do MR scans or CT scans. So we can rule out hemorrhage or other pathologies. So I'll just give you a choice now. If you are running a TIA clinic, either as a primary care physician or a secondary physician, if you get a patient with a TIA who has atrial fibrillation, would you start outpatient warfarinization? There is a 2-week wait for the anticoagulation services in our region, and then it takes 2 weeks to achieve a therapeutic range. So 4 weeks altogether. So that is option 1. Would you then otherwise give daily low molecular weight heparin, so you achieve immediate anticoagulation, and then commence warfarin, which will take another 2 weeks, which means some district nurse visits to the patient's house or some training of a family member to give the injections, because a lot of these people are elderly? Or would you start a NOAC, such as dabigatran or apixaban or something like that, in front of you, so you know the patient is anticoagulated in 2 hours, and you then send them home? I'm not going to be ashamed to say that I do the third all the time. Okay, so that was about TIAs. What about strokes? If a patient has atrial fibrillation and has an ischemic stroke, how soon should we anticoagulate them? The Royal College of Physicians 2012 guidelines have come up with an arbitrary cutoff point. What they say is, they have used the word arbitrary. They don't want us to anticoagulate the patient in the first 2 weeks. That is because of a risk of hemorrhagic transformation of the infarct. But as a stroke physician, I know, and I think a lot of people here who have dealt with stroke will also know, which is larger infarcts have a higher risk of hemorrhagic transformation. Smaller infarcts have a much lower risk of hemorrhagic transformation. And hence the Royal College themselves agree that if there are smaller infarcts, you can anticoagulate them earlier. So this is an example just from last month. I had 2 patients in neighboring bays exactly with the same problem. This patient comes in with dysphagia. She's anticoagulated at this point. That CT scan is fine. We do a post-thrombolysis CT scan. She does not improve, and you find a small infarct here in the ACA territory. So this is the infarct that caused a bit of dysphasia. The patient is doing extremely well, even though she didn't improve much with the dysphasia. She's physically well and is now mobilizing. On the 2nd of June, 3 weeks ago, you can see she now ends up with a large right MCA infarct. So the 2nd of June is less than 2 weeks from the 20th of May. So she has atrial fibrillation. We actually aimed to anticoagulate her at 2 weeks, but she does not wait. She gives us another big infarct before 2 weeks, and she dies. So 2 weeks is arbitrary. I think we should anticoagulate people with smaller infarcts within about 5, 6, or 7 days. This is another area that we come across very frequently, which is if a patient is having, say, for example, a cystoscopy or an appendicectomy or some sort of a surgical procedure. If the patient is on warfarin, you've got to stop the warfarin a week before, and then you restart it, say, for example, the 2nd or the 3rd day. It then takes 2 weeks to come into therapeutic range. So you're giving your patient 3 weeks of perioperative time without cover. I think that's a long time, actually. So this is a man who's an example, who had atrial fibrillation, stopped warfarin, recommenced warfarin, and yet ended up with a stroke about a week afterwards because their ANR was only 1.1. This is an area where there was not much guidance so far. But again, just about 2-3 days ago, we've had a publication in the New England Journal in this area. So what they've looked at is perioperative bridging anticoagulation in patients with atrial fibrillation. They have found that if you use low molecular weight heparin, when you stop warfarin until 24 hours before the procedure, and then restart low molecular weight heparin 24 hours later, it does not reduce any significant number of strokes. The stroke risk was only 3 in 1,000 for those people who did not have heparin cover. It was 2 in 1,000, which is 0.2, for those people who did have heparin cover. But the bleeding risk was very much higher for people who had heparin cover, and hence there is no case for a heparin cover in patients who are undergoing surgery. Having said that, I would prefer, if I was the patient myself, that I was using a medication that had a very rapid onset and rapid offset, which meant I could stop the medication 48 hours before instead of stopping a week before, and then restart the following day. So only giving me a 3-day period when I'm not covered by anticoagulation. I think we're all very much aware of the NICE guidelines published last year. The main points are use the CHADS-VASc score and the Hasbled score. Don't use aspirin as an agent to prevent strokes in AF. Consider NOACs in certain situations, and those situations are if your patient has 2 ANR values higher than 5 or 1 ANR value higher than 8 in the last 6 months, 2 ANR values less than 1.5 within the last 6 months, or a time in therapeutic range of less than 65%. I think a lot of patients actually fit these criteria, maybe as many as 50%. So I think the way forward would be for primary care and secondary care to work together. I'd like hospitals to do their bit as well in recognizing atrial fibrillation and anticoagulating patients. You'll be surprised how many patients go through the cardiology ward, seriously, with atrial fibrillation and discharged without anticoagulation, and through the stroke unit. So improve the recognition, improve the uptake of anticoagulation, improve the speed of anticoagulation, and make anticoagulation safer. Thank you.
Thank you, Dr. Punekar.